So it's a big update. But start for history. Rheumatology is a very young specialty. A specialty that probably exists and defined itself around 1960. But before that, we kind of know how far the rheumatoid arthritis, does it exist in the past? Of course it does. It's just that we don't call it rheumatoid arthritis. And you look at the picture here. This is a picture by a Dutch painter. This in 1593. If you look at the picture at the bottom, is this lady carrying a basket of fruit. But the hands, artists are very good in drawing details. The hands, you can clearly see there's swelling of the knuckle joints, the swelling, this is a lady, the swelling of the middle joints here of the finger. So this is probably rheumatoid arthritis in 1593 perhaps, or in the 1600s, but they didn't know that it's called rheumatoid arthritis. So where evidence, it can go way back, and of course it exists. Arthritis, those days, it's just arthritis. In today's day and age, we now have 200 different types of arthritis. And for rheumatologists to dissect and define and which arthritis you have. So there is a challenge. So the learning objective for today's talk, it is 4 points. In fact, any of these 4 points can be more than an hour talk. So can you imagine I'm going to squish them all together. I'm going to do a little bit more emphasis on the top 2, and the last 2 will be quite relatively shorter. Rheumatoid arthritis, need to think about rheumatoid arthritis in a setting of musculoskeletal diseases. We know in GP surgery, arthritis and rheumatism by far is the commonest complaint, and followed by back pain, but there are other conditions as you can see below. But rheumatoid arthritis is only affect 1% of the population, right? So but there's only one arthritis out of 200 that rheumatology is treating, remember? Just put things in context. If you do a study on 1,500 people 15,000 musculoskeletal complaints, by far the majority is osteoarthritis, which you all will have as you get older. That's part of what we call wear and tear process of the arthritis. But you look at rheumatoid arthritis, it proportionally smaller. It is more common than other conditions such as ankylosing spondylitis, but definitely less common than osteoarthritis. Right? Rheumatoid arthritis, we keep redefine what is rheumatoid arthritis. Now there's a new concept called the rheumatoid arthritis continuum. It's a continuum based on, is it a genetic disease? And I have a few slides to show you that it's not a genetic disease. Is it environment trigger? Definitely. And at point 3 and point 4 is where the area of research now heavily involved in trying to define this area. This is an exciting area there to define. What we do practice today is by the time you diagnose rheumatoid arthritis point 6, that's the day that you first met your rheumatologist. But we're now moving the goalposts to the point where we start diagnosing rheumatoid arthritis even when you are an undifferentiated arthritis stage, very early. Anything earlier than that is you don't have symptoms. But we're now beginning to show we can do some tests and predict you're going to develop rheumatoid arthritis, although you don't have joint pain at this point. So that's the area we're going to be looking at, because going forward, that's where we're going to pick out rheumatoid arthritis, treat it before it flares and become very aggressive. Yeah. So the future is looking more one step closer to looking at cure. There's no cure at this point, but we're looking into it. So rheumatoid arthritis affects anyone, all ethnic groups worldwide, but the female to male preponderance is 3-1, more common in female. The age of onset, it does vary a bit at any age group, You can be 3 years old, develop arthritis. You can be 90 years old, develop arthritis. But the peak age is usually in female childbearing age, in their 30s, sometimes in the 40s. So the 1% of the population, not only in the UK, but also in the United States. So the 1% rule, generally, it does stand. So what is this? So imagine this is a joint. So you have this two bone meat, and you have this cartilage here. So this is a snapshot of a joint, a normal joint look like. So just bear that in mind. I'll show you what rheumatoid arthritis look like in a second. But before you go on to know what is arthritis, then you need to understand what is inflammation. So inflammation has 5 signs. These are the 5 signs. It generates pain. For some of you, you might feel stiffness rather than pain, but it is a discomfort of some form. It's red because it's inflamed. There's swelling. Swelling is a very good clinical sign. There's an inflammation underneath the joints. And then it generates a lot of heat because they're very vascular in the area of inflammation. And we now know with ultrasound scan, they can see a lot of vascular flow within that joint. And this is how we picked up early disease nowadays, increased blood flow in the joint when they shouldn't be there. And of course, combination of all this, loss of function. So that sign, inflammation, is not rocket science. I can cause inflammation in my knuckle joints. If I accidentally punch the wall, my knuckles swell. I get the same kind of pain, same kind of inflammation. And I know what caused it. It's trauma. But rheumatoid arthritis is the immune system attacking the joints. So this is what it looked like. So if you look at this, is a knee, and the knee you have normal cartilage, and there's soft tissue around here. You look at this in slightly better detail. For example, this. So these are normal kind of joints. But in rheumatoid arthritis, there are tissue we call synovial tissue, which is inflamed, and they grow. They grow like octopus. Legs start to grow out. We call it pannus. So these multiple legs that are growing out continue to extend and spread to adjacent area. And you keep it growing until you control it. So untreated rheumatoid, no doubt, you damage the joints a lot faster. It doesn't damage the joint in seconds, minutes, or days, but it does take months or years. But it progresses. Once damage done, we can't reverse it. So the hallmark of treatment of rheumatoid arthritis is diagnose early, stop it, so you don't have damage. Right? So it's a damage prevention. So within these cells, if you're a scientist, you might want to know what exactly happened in this inflamed tissue. Lots of things happen. We now have targets looking at those of you receiving rituximab infusion, there are B-cell blockade. Those of you receiving biologics such as abatacept, then there's blocking a T cell down here. And of course, more of you will be on anti-TNF, perhaps like a Humira or Enbrel or similar kind of medication. They are blocking what we call cytokines. It's a chemical messenger that drives inflammation. So this is one area we block the messenger that won't drive the inflammation, that stop downstream inflammation process. And that been proved to be very effective. The joint destruction should be prevented nowadays with this day and age with the treatment that we got. Can't say the same 15 years ago, but we can say that now. The normal joints on here, you can see the arrow. This normal joint space, this normal joint space, narrowing of the joints, but not too bad. But here, definitely a lot narrowing of the joints, and you can see there's what we call erosions. Yeah. So things can change over time. And this, of course, in this setting, this is something that we shouldn't see nowadays with the treatment that we got. So why do people develop autoimmune rheumatoid arthritis? It is an autoimmune process. It's a million-dollar question that nobody knows. But I'll walk through what we know. Is it genetic disease? I said in the beginning, it's not a genetic disease. However, while there's a background risk of 1% in all population, if you have family history, you do get increased risk. But increased risk, not a lot. If you have a parent that have rheumatoid arthritis, then you may be 3% risk rather than 1%, 3 times. If you have brother or sister, you might have 2 to 4 times increased risk. So it's still 2 to 3%, maybe 4%. Even you look at monozygotic twins, that is identical twin, genetically the same, you only get 15% risk of developing it if your twin brother or sister got one. So is it pure genetic disease? No, it's not. It does increase your risk, but if you think about 1% risk of rheumatoid arthritis, you can think about those who don't have rheumatoid arthritis, they have 99% won't get it. So if you have a brother have a rheumatoid arthritis, you still 98, 97, 96% won't get it, right? So this is one way of looking at it. Why is that not a genetic disease? Because it's not a pure, while we have a strongest genotype written there, HLA-B-DR-B1, but every rheumatoid is different. You have different genotype. So it's not a pure genetic disease as such. There are multiple sites that can activate rheumatoid arthritis. And you do get, if your parents have rheumatoid arthritis, you may have that gene lying there, but they're sleeping gene. They're not activated. It's usually environment factor activated. And when they do, once they turn on, it's on. That's how you're beginning to get rheumatoid arthritis. And then we need treatment for that. But you may not get it at all, even though you have the tiny genes. This is also another slide to show, again, I just want to show you the monozygotic means identical twin. Rheumatoid arthritis have that kind of risk. But there are other conditions like ankylosing spondylitis that have more stronger family history. Okay. Environment factor is probably by far the main trigger. Now, because we go through life, have different experiences, some smoke, some don't, some eat certain foods, some drink certain alcohol, and maybe some are larger than others. Those are risk factors contribute to development of rheumatoid arthritis. Not any one of them, but combination of them. So how do you predict? It's difficult. You can't predict it. And I put in the middle, stress. Stress probably by far the main trigger before the onset of rheumatoid arthritis. And that stress can be often emotional stress, but can be physical stress. For the childbearing age woman, especially postpartum after delivery baby, is a physical stress, and they sometimes can happen after that. So we cover genetic disease, cover environment trigger. I won't cover 3 and 4 because the area that we know very little, but area that we're looking into at the moment. But I'll cover clinical features. What are they? If you have rheumatoid arthritis for 20, 30 years, you may have hands like this. But if your rheumatoid arthritis diagnosed today, or last 5, 10 years, you probably won't have deformity like this. Let's start with the mildest sign that you can find. You can see there's a slight puffiness around the knuckle joints. That's all there is on this slide. But this is slight more obvious swelling. You can spot this is swollen compared to this. This is definitely swollen, these 2 joints. Okay? And you can tell in this patient is a smoker. So the yellow nails. Smoking drive arthritis and make it more aggressive too. This is slightly worse. You can now see swelling in the knuckle joints here, but also here, but both of these as well. So this is a picture showing progression of disease. We definitely shown all MCP joint. We call it knuckle joints on both hands, and the skin get tighter too as it become more shinier, and so on. And this is something we want to prevent. And while rheumatoid arthritis is a symmetrical diseases, they do have different degree affecting, in this gentleman, right hand worse than the left hand. But by and large, general rule is rheumatoid arthritis is a symmetrical disease, affect both hands. Yeah. But don't remember it affect the feet as well. There's the ankle and the toes changes. So these are the pictures to show you, but I want to show you the next slide, which is this. The picture I show you so far are all hands and feet. And it's true, hands and feet responsible for, you look at here, hands, up to 90-95% of the rheumatoid patient. And you look at the feet, also up to 90% involvement. So hands and feet by far the commonest joint involvement. But of course, it can affect other joints. Some can get neck involvement in 40-50%. Of course, shoulder 60%, elbow up to 50%, and so on. So hands and wrists is the commonest. Feet, while it can affect by rheumatoid arthritis, but also affect by degree of wear and tear, because your feet have to carry your body weight all your life. So there will be some mechanical arthritis called osteoarthritis. So feet is slightly more complicated. They're usually a combination of inflammation and mechanical. This is another picture I showed you already. Just to recap, if you can see this normal joint space, narrow joint space, very narrow joint space, and the erosion. This is the feet. Wear and tear osteoarthritis tend to affect the big toe, but rheumatoid tend to go down, affect the smaller toe. This erosion here and joint space narrowing, as well as the fourth toe here, erosions here. Now these are X-ray changes. I remember when I was a registrar, we used to do an X-ray of the hands and feet every year and monitor progression. And now we have ultrasound. Ultrasound can predict joint erosion 2 years before X-ray changes, which make us treat rheumatoid arthritis 2 years earlier with clear evidence and good monitoring tools. So these are rheumatoid nodules, where you can have nodules around the soft tissue, usually around the area of pressure. Why that spot? Because that's where most of us, when we're sitting around the table, you put your hands and lean on the table. That's the area of pressure. And sometimes you can get at the back of your Achilles, because our shoe, our leather shoe particularly, rub on the back of the Achilles, and there's area of pressure. The rheumatoid tend to accumulate, the nodule can happen. Not everybody get them, but those who get them usually around the area. Of course, you can get in the hands, depending on the nature of your work. If you're a gardener, you might get nodules on a finger. But of course, rheumatoid arthritis is not just a joint disease. It's a multi-system disease, which can affect your lung, your heart, your blood vessel, potentially. So the treatment itself, while it is for your joints, because you can feel the pain immediately, relieving the pain is important, but actually the secondary treatment is that you prevent multi-organ involvement. We know rheumatoid arthritis has twice increased risk of ischemic heart disease, same risk as the diabetes, and that's why treating tight control of rheumatoid arthritis is beyond just, I think your joint's okay, but actually, if your blood tests still show very high level of inflammation, your ultrasound scans still show active disease, you probably get used to your pain and don't feel too much about the pain, but there's still reason to treat a bit more aggressively. And there's something that discussed in consultation, and we are really tight control. And the rationale of tight control is clearly evidence-based for many years now. But I don't think we do it right all the time, but it's something we should do better. Yeah. So rheumatoid arthritis is a clinical diagnosis. I show this slide because in 1987, this is how we used to diagnose rheumatoid arthritis. And right at the bottom, we say you need at least 6 weeks of symmetrical disease, more than 3 joints involvement. Now there's leg disease in this day and age. We're now moving forward and diagnose earlier and earlier with just one swollen joint that is unexplained. We want to know whether there's rheumatoid arthritis. So these are the latest guidelines, it's 60 years old now. And you look at the top bit, it's all concentrate on number of joints. The more joints you have, the more point you score. When you are score 6 or more, you are not possible, not probable, you are definite rheumatoid arthritis. Right? And that combined to the middle group, which is blood test, measure your antibodies profile, that will score some points. And of course, duration of symptom more than 6 weeks is now only downgraded to 1 point. It's not a must, it's a score that you can include. And CRP, ESR, most of you know, is a marker of inflammation. If they are raised at presentation, they also score a point. So you can see diagnosis become earlier and earlier. And remember, we can also diagnose this prospectively. You may have 1 joint pain, the first day you see a rheumatologist, a month later you might have 3 joints. The score go up, right? So you do prospectively change from your maybe rheumatoid, possibly rheumatoid to definitely rheumatoid. But this is only clinical diagnosis. With the ultrasound scan, you can scan it much earlier, and you actually have more confidence and put someone on strong medication far earlier because you're not mistreating, you're definitely seeing an inflammation, and plus some of this score, you're actually able to treat early. The danger of treating too early is, remember, there's other type of arthritis, which may not be rheumatoid, which does not need methotrexate, right? Anti-CCP, just one slide. This is one important antibody profile that hopefully one day the GP can request it. At the moment, only specialist rheumatologists can request this. This is a very good test. There's limitation. Anti-CCP antibodies is a predictor of you develop rheumatoid arthritis even before you get joint pains. So the specificity at the bottom here, 98%. Is how specific it is. You get anti-CCP at high level, low level, debatable, but high level, you are going to develop rheumatoid arthritis. However, in a very early disease, only about 50% may get this positive test, which means the other half may not get this test to guide us. But in the established disease, a 3/4 will get these antibodies. But at least the 50% will have this high level even before they get joint pain. And in some countries, they do that. In some countries, in Japan, they do a routine anti-CCP test for any well-man and well-woman clinic where you go have a routine check, your cholesterol, your blood sugar, your blood pressure. They also check anti-CCP. Now, this patient doesn't have any joint pain. But when it's positive, they refer to rheumatologists, and they will follow them out and teach them to show them what rheumatoid arthritis look like. So the moment they develop some swollen joint unexplained, they know this may be beginning of rheumatoid arthritis, and then they start treatment. That's the earliest possible treatment one can give. So we're far from doing that screening test because this test has some cost. So we can't at the moment in NHS to do tests for everybody. But hopefully, as the costs come down, it becomes routine in the future. I mentioned before, ischemic heart disease is increased by twice if you have rheumatoid arthritis. So it is very important, talk to your GP to control your cholesterol, your blood pressure, check your blood sugar, and your weight. Yeah. The figure here of psychosocial impact is great, but this data is in 1996, before we know how to use the treatment properly. So it is a lot of psychosocial impact on any individual 20 years ago, But now with tight control, we know how to use the drug that we got. And also, if you don't respond, then we have biologics therapy. So we are a lot better. So this number is a lot less nowadays. So what are we doing in rheumatoid arthritis treatment? I mentioned about tight disease control. At every single case, aiming for remission. Obviously, you have to cater for individual patient. Yeah, you need to take side effect into account, but remission is what we aim for every single case. While we definitely slow down the disease, but we hope we can stop all cases disease progression. And then you go back to normal life. And the rheumatoid arthritis, when you first diagnose, on day one, is a huge bubble of your life. It's perhaps the whole of your life on day one, first day. And the job is that we work together and try to shrink that bubble down to tiny little bubble of your life. It's not going to burst because it's a condition that you're going to live for the rest of your life, but it's going to be a tiny bubble. You can go on to have your social life, go and carry on your work, if you're still within the age of working, have hopefully minimum impact to your daily life. And there's another story, which is the self-management program we'll run. But if you're interested, I got self-disease activities school workshop at 12:45. You can come and join me or explain further about what to do. So tight control of rheumatoid arthritis is become the standard, the norm of all rheumatologists practice nowadays. Early disease, tight control. So what do we have? You take your journey over the last 100 years or more. We only have aspirin to begin with in 1900. Then we have a fantastic drug called Go, and the Go is actually a very good rheumatoid drug, even today. The only problem of Go for today is that it takes a year to work, which is too late when we want to tight control, treat early, but it does work. That's still the fallback drug if nothing else works for some of our patients. Then some of the drugs you might recall. But if you come to the last 10, 15 years, those in yellow, started in 1999, so the last 17 years or so, the explosion of drugs, not one, not two, but more than 10 drugs. And these are what we call biologics. These are biologics. Why call biologics? Because unlike methotrexate, they are not chemically synthesized. Methotrexate is a chemical. So chemically synthesized, you can, once out of patent, any company can use the formula and recreate it. Biologic is different. Biologic is biologically synthesized from guinea pig for animals. So their biological process produce antibodies that you give it to you to target the cytokine, the chemical that drive inflammation. And that's how we use it at the moment. And that is why no one biologic is the same. Yeah. But these are so-called the wonder drug. But the wonder drug come with a price. You may already know this drug costs £10,000 a year. But £10,000 a year, while it's very, very expensive, but actually it's very cost effective because it gets you back to work. You pay taxes. You are independent rather than become dependent. So all those add up. The saving is 10 times more than £10,000, which is why we can use this with the NHS because it's cost effective. This is a busy slide, but I want to show you just one point. While we have all those in yellow are the ones available in NHS that we can use for about 15% of our rheumatoid patients. 15 to 20%. Majority will not need this. They can be controlled with just methotrexate and one other drugs, perhaps, for majority of the patient. But for 15 to 20% of the patients, they have quite aggressive disease. They're so aggressive that methotrexate, sulfasalazine, some other drugs is not working. It may be partially treated, but not working completely. And that's why you qualify for these drugs, and most patients will respond. Now, all these drugs that's available in yellow, the red are not available in NHS, but the one available in yellow, they are dealing with mechanism outside the cells. in the blood. So anti-TNF therapy, some of you are taking, floating in the blood. So they're blocking it. Or the way they work, they had to combine to a receptor on the cells. So we block the receptor, you're still blocking it. But we're still outside the cell at this stage. The new frontier is now developing a medication that's targeting further downstream inside the cells. And that shows some huge promise, and it being approved in some countries, in the United States, the one at the bottom, tofacitinib. That's the first generation. The second, third generation is now coming out. In fact, the third generation is what we're doing clinical trial research in the unit. So some patients are put into that treatment arms. That's probably the future, because it's a tablet, no longer injection or infusion. It's a tablet you can take. Yeah. So the paradigm shift of rheumatoid arthritis, what are we doing? You do nothing, disease progress. The first day of symptoms, in fact, is where you want to start treatment. 15 years ago, we may wait for X-ray to change before we put someone on methotrexate, because physicians not worry about chemotherapy. Methotrexate is chemotherapy, and patient also not keen. I don't have cancer, why am I taking these drugs? But they forget that methotrexate that we use is 200 times, or in fact 100 times weaker than the chemotherapy. But you treat, by the time X-ray changes, you at best slow down the progression, but it still happens. But you treat a bit earlier, this one, that it still has some progression. But what we really want to do in an ideal world is that the day you saw rheumatology diagnosed rheumatoid arthritis, the treatment start then. And hopefully, it does take 2 to 3 months, but hopefully that 2 or 3 months switch off the inflammation. The moment you switch off inflammation, there's no disease progression. And that's we can probably safely say 70-80% of our patients, we can achieve that within 3 months to 6 months at the most. 2009 is an important year. It's called the year of rheumatoid arthritis, because that is the year where concurrently you have many reports from King's Funds, from NHS, and from National Audit Office saying all the same thing. What do they say? They say that you need to treat rheumatoid arthritis. If I go back just one slide, you need to treat rheumatoid arthritis aggressively with not one, but possibly 2 strong medication. Methotrexate has to be one of them. Treat early, aggressively, and then the outcome will be better. And they all said the same thing. And of course, changing practice and changing culture up and down different departments up and down the country requires some mechanism to make it happen quicker than it is. So the mechanism in 2013 looks like this. Remember, you all know that if you have cancer or suspected cancer, then the hospital needs to see you within 2 weeks. But if you have suspected inflammatory arthritis or rheumatoid arthritis, then we need to see you within 3 weeks. So there is a service called best practice therapy, and we deliver in hospital, and primary care has a similar kind of target. So it's a mechanism that drives better management of rheumatoid arthritis, early treatment, early disease management. Okay. And we are fortunate in Portsmouth that we're able to meet that target, but it's not the same for all departments in other parts of the country. So in summary, I will have a few cover you briefly about pathogenesis of rheumatoid arthritis, a brief journey about medication, last 100 years. Of course, tight control, and which is why sometimes we suggest more treatment even when you come to clinic. And it has to be individualized, I must say, depending on your need and your targets and your goals in your life. And of course, the current state of rheumatoid care, it's getting better and better and better. So I left you with this, that is one of my favorite quotes, and it is, William Osler is the father of modern medicine. He's the one who actually changed medical school teaching. Before, he introduced, before him, medical school is medical student read textbook for 5 years and never see a patient until they become a doctor. And he said, really, we really need to not treat the disease, but treat the patient who has a disease. Then he introduced the medical school, at least 2 or 3 of their years need to be bedside teaching with the patient, which makes sense now, but at that time, it wasn't the norm. So, thank you. Any questions?